let me share with you some data and our initial experience. Those outlined earlier slides show theoretical advantage of artificial intelligence, but let's look at the numbers. Does it really make a difference? So we conducted a study of initial study after implementation. It took 5 months after we actually established a team and had all ducks in a row. Essentially, we performed, took 5 months after initial implementation from December 22 to April 23, and analyze prospectively all scans with contrast that we will perform for any reason for abdominal aortic aneurysms. All those scans that were performed without contrast obviously were excluded. Next slide, please. So after 5 months, what we found, there were a total of 446 aortic measurements more than 3 centimeters, essentially 446 aneurysms in the whole system identified. Interestingly, that 188 patients had abdominal aortic aneurysm diameter more than 4 centimeters. And out of that number, 46 patients, or 24%, were newly diagnosed. So the patients didn't know about the existence of abdominal aortic aneurysm, as well as their primary care physicians. After evaluation of comorbidities and other patients' characteristics, 16 patients were considered not suitable for any further follow-up or repair, mostly due to severe cardiovascular comorbidities or presence of advanced stage cancer. When we analyzed the age of the patients, only 4 patients were outside of traditional screening guidelines set by Society for Vascular Surgery. So majority of these patients really were within the screening guidelines, but for various reasons didn't get any screening of their abdominal aortas. And out of that category, 30 patients, or 65% of de novo diagnosed AAAs, were then scheduled with various providers for routine follow-up, and where it was indicated that was scheduled actually for repair. Next slide. So in conclusion, from this early experience over 5 months of implementation, we saw that the algorithm can consistently identify the pathology and measure the aorta above 3 centimeters. And it can be adjunct to traditional screening, as it can actually identify additional patients that for various reasons didn't undergo the screening. And potentially this can further decrease the rupture rate, but we still have to follow and use this system for a longer period of time to demonstrate that the truly rupture rate is decreasing.